Okay, thank you, dear colleagues. I will speak now about arthroscopic guided Latarjet using two cortical buttons. It's the Boileau's technique. A few words of introduction before starting with the techniques. We all know now about Bankart repair on the Latarjet. We know that for Bankart repair, we have a rate of recurrence from 0 in some studies to 37, 38%. In open Latarjet or with arthroscopic Latarjet, the recurrence rate is lower. And if for studies with long-term follow-ups, we have seen that Latarjet is better than Bankart, but as you know, it's the French point of view. The problem when you do the Latarjet, even open or arthroscopic with the screws, is the screws. So sometimes you have a problem with them. We want to solve this problem. Another problem is the malposition of the bone block using the screws. Finally, you have a high risk of neurologic complication. And with open Latarjet, you have more or less 10% of risk. But if you make neuromonitoring during your surgery, you have more or less 3/4 of nerve alerts. The concept of a double button is what? Is first of all to reduce the screws risk. Second one, to achieve the same clinical functional outcomes that you obtain with the other devices. And finally, to combine different surgeries, because in the same time you can make an arthroscopic Latarjet and also a Bankart. So we make a study in the Nice University Hospital from December 2012 to June 2015. The inclusion criteria was an EASI score superior to 3 with an anterior glenoid defect up more than 15%. We choose to conserve only patients with at least 2 years follow-up, and patients with previous ability operation failed were not excluded. It was guided surgical techniques. We have patients in the position of lazy bed chair, guided instrumentation, the 5 classical anterior portals and 2 posterior portals. We use a suture button fixation, but I will show you some tips and tricks and a video in this afternoon. What about the series? We started with 136 patients, but 15 of them were lost to follow-up. And finally, we can analyze 121 patients at least 26 months follow-up. Mean age was 27. We have a majority of male. Dominant arm was involved in 2/3 of the cases. We have some smoking people, and as you can see, the EASI score was the mean EASI score was 5.5. How we evaluated them? First of all, with the imaging, we make an X-ray and a CT evaluation at 2 weeks post-op, 6 months, and more than 1 year post-op. With this imaging analysis, we analyze the graft position in the axial and sagittal plane, and also the graft union. What about the graft positioning in the sagittal plane? We can see we have assessed that we have a good position, subequatorial position, in 92.5% of our cases, and equatorial positioning in 5.8%. As you can see, only 1.7% of supraequatorial, which is not quite good, but it was in the beginning of our experience. What about the axial plane? We can see again that we are flush in 85% of the cases, never to medial. It's due to the guided technique. And in 6 cases on the 131, we are a little bit too lateral. But as we can see, we will see a little bit later, it's not affect the results. The bone union was also quite good because we have 95% of complete union and only 3% of non-union. So, but don't be afraid if your CT scan or X-ray is not so good at 6 months, because we have noticed, especially with smokers people, that at 6 months we have some bad images, and we are a little bit afraid of that. But when we make another CT scan at 1 year's follow-up minimum, we have a complete healing of a bone block. Why the lateral positioning is not so a bad thing? Because we have some kind of flexibility, and if at the CT scan made 2 weeks after the surgery you have some patients with a lateral overhang, we can see that for 5 of the 6 patients at 1 year follow-ups, the lateral overhang was less than 1 millimeter. So maybe we can think that button fixation may allow some degrees of axial repositioning, maybe also due to the conjoint tendon. We also noticed remodeling of the superior part of the graft. As we know, we have, with the screws, usually we have some resorption of the upper part, and the same goes to with a double button. But as we want just to make the glenoid like a pier, you see at the 24-month follow-up, the objective is okay. What about clinical results now? We have, for our patients, quite good clinical results also, because raw score was 94.9, Valge duplex score was 92.1, and SSV score was at 94%. But what about the score? Because this procedure is for young people and athletes. The return to sports was good at 93%, but with no apprehension in 95% of cases. But when you are competitive athletes, it's a little bit different. Only 71% of them should do their sports at the same level after the surgery, especially when you are a contact or overhanging sport or sport with high risk. The results are a little bit less good than for normal people. As you can see, this guy was a breakdancer and can't do breakdance anymore. And after the surgery, 6 months after the surgery, he was able to do that again. What about the complications? Professor Ludwigsen say that in their experience they have no major complications. The same is, it was the same for us too, because we have no neurologic injury, no infection in our case, no hardware complication, but we have some hematoma, probably due to a bad bleeding control. As you can see, why we don't have neurologic injury, it's also because when the bone block is fixed in the anterior position, we can make a little release of the conjoint tendon, just not to be too tight. What about recurrence of instability? We have only 1 patient with recurrent instability in recurrent dislocation, sorry, in our series, and 3 patients with recurrent subluxation. 3 of those 4 patients need a revision surgery. There are the 3 cases that you can see. 1 because the graft was too low, 1 because he was a smoker and have a medium Ilsachs lesion, and 1 with a deep Ilsachs lesion. For the 2 cases on the right, we just make an Ilsachs remplissage, and they were happy at last follow-up. But even if you have severe complication as a non-union of the graft, the button minimizes the severity of this complication because it's not screw and it's not on the head, human hair head all the time. So you can see this guy have no bone block union, but he have an SSV support at 95%. He returns to full activity in his basketball player. He has no recurrence anymore, and Valge duplex raw score at 100. So guys, what should we prefer this technique now? The first reason is that it's a guided technique, so we have an accurate positioning of the graft. I remember you that we have 95% of good positioning in axial position and 92 in sagittal position. The second one is that everything is under control, because when you are in the front, you can control the artery, the nerves, and I will show you with a video on this afternoon how you can do it to be always in the safe position. The third reason is that you have a good bone healing, same that the one you have with the screws. So why not use a button? And the fourth is that suture button fixation is an excellent alternative for us to screw fixation, because as the bone block healed, the return to sport is better. Why not doing it? Thank you very much.